what we call the classification and the treatment of ovarian hyperstimulation syndrome. Let's have some introduction about it. The most of the problem resulting from the gonadotropin therapy. Those ladies who have been exposed to or been complicated with the hyperstimulation syndrome, they were on what we call ovulation induction therapy. And most of the time, we are using the gonadotropin. This will stimulate the ovary to produce more eggs. The two most important serious complications of excessive ovarian stimulation is the higher incidence of multiple gestation and ovarian hyperstimulation syndrome. Whenever anybody talk about the ovulation induction, you put in your mind that you may land ended by multiple gestation or ovarian hyperstimulation syndrome. The abbreviation for the ovarian hyperstimulation we use the word the OHSS refer to the combination of ovarian enlargement. The ovary get enlarged with the multiple ovarian cysts, acute fluid shift out of the intravascular space. It's potentially life-threatening complication of ovulation induction. Okay. Let's see how we can classify the ovarian hyperstimulation syndrome. Grade 1, or what we call it, a mild bilateral ovarian enlargement with the multiple follicles. Corpus luteal cyst measuring up to 5 by 5 centimeter. The laboratory finding includes serum estradiol concentration greater than 1,500 milligram and progesterone concentration greater than 30 nanogram in the early part of the luteal phase. We have three categories here: bilateral enlargement, corpus luteal cyst, which 5 centimeter, and the creeping up level of the estradiol as well as the progesterone. Let's see the grade 2, the ovarian hyperstimulation syndrome. Ovarian enlargement up to 12 by 12 centimeter. Now the ovary getting bigger. Abdominal discomfort, gastrointestinal symptoms, and being presented as nausea, vomiting, and diarrhea. Sudden increase in the weight of more than 3 kg may be in the as an early sign of moderate hyperstimulation. Those ladies being exposed to ovulation induction for the assisted reproductive technology to seek the solve the problem of their infertility, they have to put in their mind, if their weight increase, okay, then this is alarming that they have something cooking, which we call it ovarian hyperstimulation syndrome. Grade 3, we notice now the presence of large ovarian cysts more than 12 by 12. The mild was 5, the moderate was 12, and the severe type or grade 3, which is more than 12 centimeter. Now in the severe type, there is ascites, which is a collection of fluid in the abdomen, and pleural or pericardial effusion. There is a disturbance in the electrolytes, which has been noticed as hyponatremia or hyperkalemia, hypovolemia, and hypovolemic shock, marked hemoconcentration. That's why we the first slide I mentioned that it's a life-threatening situation. If the lady reaches the stage 3, it's a life-threatening. increase in the blood viscosity, and thromboembolic phenomena. Sometimes, some of these ladies, these symptoms regress, which is, we notice this in our practical life. And this takes some time, 10 to 14 days. Okay. The pulmonary manifestation with the ovarian hyperstimulation started with the pulmonary infection, thromboembolism, acute respiratory distress syndrome, and a lot of people, they notice the respiratory distress syndrome, which is more common, the type 2 and more. The pulmonary manifestation, dyspnea, which is difficulty breathing, tachypnea, respiratory rate is higher, moderate hypoxemia, increased alveolar arterial oxygen difference, hypocarbia, respiratory alkalosis, metabolic compensation. See how serious the story starts? From treating ladies for infertility, then you end by patient in the ICU. What are the thromboembolic complications? The thromboembolic manifestation are the most serious, are the most rarest complication. Thrombosis can be occur in either in the arterial, which is about 25%. Venous is more common. Okay, and this can cause what we call a neurological injury or death. It's probably related to hemoconcentration. As we discussed, that there is shifting from fluid in the intravascular shifted to the extravascular. That's why there is a hemoconcentration. And the sequelae of hemoconcentration is the thrombosis. And the shifting of this fluid, this is due to increased permeability due to high level of estrogen. Again, there is also a disturbance in the clotting factors. There will be high level of factor 5, platelets, fibrinogen, fibrinolysin, and fibrinolytic inhibitors. Okay, increased thrombosis generation in women with the OHS. A woman with the genetic thrombophilia, okay, they are more at risk developing thrombosis. That's why any lady is going to have sit for the program of the assisted reproductive technology for IVF, and she is going to be exposed for gonadotropin therapy. We have to screen them for thrombophilia. And this is some center, they do this business. The thromboembolic complication of this has been reported in the internal jugular vein, subclavian vein, axillary, and mesenteric vessels. Okay. In one series, 5 cases of internal jugular vein thrombosis presenting of 7 to 10 weeks of gestation after IVF. The lady is pregnant with a multiple gestation, but we notice these manifestations. Here we are, another serious complication, which is the stroke. If there is a thrombosis in the brain, this is the end result. Thrombosis has been reported in some women with severe ovarian hyperstimulation syndrome. let's talk about some statistics. In those cases who been have exposed to ovulation induction, the moderate type, which reach about 3 to 6%. The severe type, which is a little bit smaller. Okay. If the and this is the routine businesses or routine or protocol in the assisted reproductive technology. They do what we call a sonographic monitoring of ovulation induction. And this will minimize to some extent the incidence of hyperstimulation syndrome. Okay, the lady, she will have a serial ultrasound for measuring her follicles number and size, and they can discover if there is enlargement of the ovaries in the meantime. What will happen to the pregnancy? This we tackled some of the pathophysiology and some manifestation. Inducing a mild or ovarian stimulation appear to be beneficial for increasing in, pregnancy rates. Lady, she is infertile for 5 or 10 years, and she is really dying to have a baby. I mean, when we counsel them, we sit with the ladies and tell them we have the protocol of ovulation induction, and one of the side effects is the different types of ovarian hyperstimulation. She have to be aware of that. But most of them said, all right, I hope I will have the mild type, but there is no limit. Okay. Anyhow, if the lady, she's been exposed to what we call the ovulation induction, you can monitor her ovulation, the size of the follicles by doing an ultrasound. And if the treating doctors think there is an alarming signs of ovarian hyperstimulation, he can tell of the therapy, and he can do the proper management in the meantime. The mild hyperstimulation also see the incidence of higher multiple gestation. Okay. And those cases with the hyperstimulation with the mild type, they may end by spontaneous miscarriages or abortions. And there was a lot of study indicated that the incidence of miscarriages related to on top of the of ovulation induction therapy, and all these being concluded that the more multiple gestation, the higher chance of spontaneous miscarriage. Okay. Also, the possibility of multiple, as I said, triplet and quadruplets, and sometimes you have maybe 5 or 7 babies. Okay. How we treat? Now we confronted with the case with the ovarian hyperstimulation. What we have to do? The best treatment is primary prevention. Preventing ovulation by withholding the human chorionic gonadotropin, which is an effective method of avoiding hyperstimulation. We tend to give the lady this hormone. This will stimulate the release of eggs from the Graafian follicle, and and this is proof. Is the if you withhold or if you don't give this injection, human chorionic, the chance of hyperstimulation will be small. Again, if you're confronted with a large number of follicles and there are huge numbers and bigger size, you may do aspiration of these follicles. And this will reduce also, because if you aspirate, you reduce the volume of the estrogen in that follicle, and this will reduce the incidence of hyperstimulation syndrome. The ovarian hyperstimulation, being told, is a self-limiting disease. Thus, treatment should be symptomatic. We treat symptom and conservative. You have to do a conservative management as much as you can. Medical therapy suffices for most patients, with the laboratory reserved for the catastrophic complication. One of the when we say catastrophic complication, we're talking about ovarian torsion or ovarian hemorrhage, rupture of this ovarian cyst, and this will end by hemorrhage in the peritoneal cavity. Women with severe symptoms often require an intensive medical care, and we tend to ask our lady with the ovarian hyperstimulation to avoid sexual intercourse. Okay, and this because the sexual intercourse will cause what we call making a pressure on these large cysts and tend to be ruptured sometimes. If we have a case with the grade 1 hyperstimulation, the treatment is supportive and is needed. However, mild ovarian stimulation can develop into a moderate or severe. That's why there is no cut-off point. The lady, she can progress quickly from mild to the severe type. Okay, what you have to do, you're good to do with those cases with mild type, you do what we call, you can just see the abdominal girth. You can observe how the abdomen gets bigger, her weight, and she will have what we call abdominal discomfort. 3 points has to be watched and observed, as I said, enlarging abdominal girth, acute weight gain. The second type, which hyperstimulation, how we deal with that, what we have to do, observation, bed rest, adequate fluid, because there is a fluid disturbance, and sonographic monitoring of the ovarian cyst, serum electrolytes, hematocrit, creatinine should be evaluated, initiation of resolution. Okay, the cysts become smaller sometime. Okay, and you can observe this by the ultrasound and symptoms wise. Okay, again, early detection of progression to severe form can be manifested by continuous weight gain, increased severity of form of the existing symptoms, and appearance of a new symptoms. And the lady will have these symptoms of vomiting, diarrhea, and dyspnea. The severe type, what to do? Maintaining the blood volume, because there is hypovolemia, while correcting the disturbed fluid and electrolyte balance, relieving secondary complication of the ascites and hydrothorax, preventing thrombosis, laboratory test, frequent monitoring of vital signs, and you good to check the input and output, weight, and you good to deal with the hypovolemia. Okay, this as a serious communication. Okay, the lady who's been ended by hypovolemia, she is really a case of hemoconcentration. Her blood pressure will be deteriorate, tachycardia, and this will end by renal disturbance and decrease renal perfusion. And you can uh, notice by that the lady, her urine output is less. Okay, the management of hypovolemia is, uh, is an ICU business. Okay, you got to replace fluid, you got to give the appropriate doses of the electrolytes. You got to do a plasma expander. Some centers, they tend to use a human albumin. They give sometimes the plasma. Okay, oral indomethacin, and this will reduce, block the prostaglandin synthesis. Okay, the hematocrit has to be monitored every 4 hours. Plasma expander can be stopped when the hematocrit is less than 38. Okay. The use of diuretics is not recommended because the lady, she is in hemoconcentration. Some center they use the diuretics, but it really is not fully accepted business. The lady with the hypovolemia may end by renal failure. Okay, and you go to consult the nephrologist to deal with. What to do with the ovarian enlargement? I'm not going to take longer with you, but yeah. The lady, she had grade 3 with the large ovaries. Okay, as I said, the chance of torsion that this ovary may get twisted, or these cysts may get ruptured. Okay, right. Treatment may require some time. You got to do oophorectomy if this is, and you can avoid oophorectomy by just if you untwist to the laparoscopic or laparotomy technique. Again, the ascites can be reduced by doing aspiration. Okay, and people sometimes they aspirate from the acidic fluid and infuse it back to the because the in the acidic fluid there are a huge volume of albumin. What to do with the pleural effusion? Again, the woman with severe type involving the lung parenchyma. Okay, and you got to do pleural effusion should be drained and relieve the dyspnea. Again, the thromboembolic, what to do? People sometimes, as I said, this is if you confronted with a lady with the severe type, and there is a manifestation of thromboembolic manifestation, you got to do what we call prophylactic anticoagulant, and tend to do that before the incident. And this according to the center. Some center they give, okay, and the anti-embolism stocking, or they use what we call the boots like pneumatic compression. A resolution, and alhamdulillah, sometimes these cases, as I said, resolve. Okay, and some of the fluid go back to the okay, and this will reserve the hemoconcentration. Okay, and this, as I said, it takes between 10 to 15 days. Okay. All right. As I said, summary, I go to careful monitoring blood volume, correcting electrolyte. Thank you very much. And I will leave the floor for the questions, remarks. If you have any queries, I apologize for the technical problem at the beginning of the talk. If you don't have any queries or remarks, maybe we can shift to the welcome our next speaker.